Good morning. For those of you asking about audio, we are giving everyone one more minute to join us, and then we will get started.
Good morning, everyone. Welcome to the webinar titled Building the Evidence Base for Disaster Risk Reduction for Health Systems in Response to Natural Disasters. My name is Tricia Castranio, and I am a Sustainability Analyst at the National Institute of Environmental Health Sciences. I will be serving as your moderator today. By now, you should have the WebEx application running and should see the welcome slide on your screen. Because you will be muted throughout the webinar, please direct all questions, either technical or content related, using the Q&A box on the right side of your WebEx application. You are welcome to submit questions throughout the presentations, but note we will address the content-related questions only during the Q&A sessions. Again, please be sure you are using the Q&A feature and not the chat box. Keep in mind that only the panelists will be able to see your questions. The wider audience will not. And unfortunately, we may not have time to address all the questions submitted today. However, following the webinar, we will provide a link to resources and contact information for our speakers so you may reach out directly to them. As a reminder, today's webinar will be recorded. I would now like to introduce today's panel moderator, Dr. John Balbus. John Balbus serves as a Senior Advisor to the Director on Public Health Issues and as the NIEHS Liaison to external constituencies, stakeholders, and advocacy groups. He also leads the NIEHS efforts on climate change and human health. In this capacity, he serves as HHS Principal to the U.S. Global Change Research Program, for which he also co-chairs the Interagency Cross-Cutting Group on Climate Change and Human Health. John, the floor is yours.
Great. Thank you so much, Tricia, and welcome everybody to this first webinar in a series. We know we have folks from all around the world, and we're really grateful to have you on the line with us today. Our webinar today is part of a larger effort whose ultimate goal is to create more resilient healthcare facilities in the face of increasingly severe natural disasters. NIEHS, National Institute of Environmental Health Sciences, the National Center for Disaster Medicine and Public Health at the Uniformed Services University of Health Sciences, and the National Institute of Standards and Technology, or NIST, are working together and reaching across the federal agencies to improve the science of simulating healthcare system responses to natural disasters through integrated modeling approaches. Our goals are to build an understanding of the critical tipping points in the vulnerability of current health systems, including not just the buildings and the infrastructure, but also the human staff during natural and human disasters. And we're also working to build an evidence base for specific risk mitigation measures. To do this, we're holding two webinars, with the first one held today focusing on the current state of the science in predicting health system responses to disasters, and the second one to be held next week, focusing on current approaches to decision-making regarding health system preparedness and resilience, and helping us to identify unmet scientific and analytic needs. And then, building on these two webinars, our interagency group is going to hold a closed conference of federal program staff to help define shared priorities and to start to build a roadmap for scientific endeavors in this field. So we're extremely fortunate today to have an outstanding set of speakers for the webinar. They will each address different components of the causal chain from natural disasters and extreme weather events through infrastructure and health system impacts and ending in human health consequences. Today we're going to go through all four speakers, as Tricia has mentioned, and then, assuming I do my job as timekeeper well, we'll have time at the end to have questions provided through the WebEx system to the panelist speakers. So with that, let me introduce our first presenter. His name is Gary Guinart. He's the Director of the Climate and Environmental Sciences Division in the Office of Biological and Environmental Research, which is an office in an office. It's in the Office of Science as part of the U.S. Department of Energy. Gary oversees and directs basic scientific research at DOE national laboratories and universities, including atmospheric, climate, and environmental sciences. Besides his duties within the DOE, Gary serves as the vice chair and/or as the Department of Energy principal to 4 science committees within the White House National Science and Technology Council. Dr. Guinart earned his bachelor's degree in atmospheric sciences from the University of California at Davis, his PhD in atmospheric sciences from the University of Washington. He's well published with 4 technical books, over 100 journal articles in his career, and he's a fellow of the American Meteorological Society. So with that, Gary, let me turn it over to you.
Okay, can everybody hear me? Okay. John?
Yes, I'll unmute myself, and
okay.
You sound great.
Okay, perfect. So thanks everybody for joining this this meeting. I'm just going to give a kickoff to set the stage for the remainder talks, but my title is a bit, I would say it's almost too high level. I'm going to be talking just about integrated analysis and the history of where we've come to from the past 50 years, and make some suggestions of what I think some of the challenges are. We can actually discuss those throughout this webinar and towards the end. So next slide, please. So if we move to the history of where we've gone for the past 50 years, if we go back to the 1960s, most of the emphasis on integrated analysis or integrated modeling started off with EASA-type activities in Europe, where they're looking at acid rain. Climate change started to become a central theme by the 1980s, and that branched off into more specific topics like water infrastructure, energy infrastructure, getting into health infrastructure and health issues, certainly by the 1990s and 2000s. And then more recently, and I'm going to say this is more recently because especially of computer power, which allowed better processing of data, models to become more higher resolution, but getting into issues like cascading failure, ties to weather, and really expanding into weather and climate really during this past 4 or 5 years. More recently, I think the community has shifted much more emphasis towards disasters, especially in the past 5 to 10 years. It goes back to Katrina more than 10 years ago, but this year with some of the hurricanes which impacted some U.S. coastlines. I'm going to talk about especially Maria, or let's say hurricanes which not just impacted the coastlines, but started to become repeating events where the communities and the states and the local counties didn't really have enough time to adjust to a previous disaster. And that's where the difficulty came in. So let's move to the next slide, please. If we go back in time to some of the taxonomy, which is started out in the 60s but extending up through today, most of the early work focused on more statistical analyses, which they call PIA, and that really started especially in Europe, but it started to bridge over to the US EPA by the 70s and 80s. But the integrated analysis modeling really started to emphasize during the past few decades all types of impacts associated with climate change. The types of time horizons were years to multiple decades. We started to look at the limitations of these models, and those limitations started to help guide the research investments to improve their capabilities. During the past decade, a new branch started to emerge called IAV, Impact, Adaptation, and Vulnerability Modeling. This was especially prevalent within the Department of Homeland Security within the U.S., but there were other organizations in Europe that were doing the same thing. But it was looking at disasters, response, and resilience. They started out looking at weather impacts, so the time horizon for these IAV models was out to several weeks. They didn't look at climate impacts until really recently. The features which they advertised as part of their codes were mainly the natural system, but they started looking at socioeconomic impacts and behavioral impacts of different population groups, especially since Hurricane Katrina. But I would say that is a unique feature of the IAV models compared to previous ones. They wanted to look at the modeling of social response. During the past 2 years, I would say, there's been an effort to combine integrated assessment models on longer time scales with these IAV models on really short time scales, where the IAVs were nested within the integrated assessment models. And that's become a huge challenge computationally and with data, because it's, as any hybrid model goes, one has some enormous computational challenges to look at the couplers between these models and how one can nest the information and upscale nested information across different grids. So let's move to the next slide, please. And this is where we get into sector interdependencies. Both IA, integrated assessment models, and these shorter-term IAV models, they look at the combination of human systems and natural systems, and you can see from this slide, the lower half is the natural Earth system, and you can read these slides as well as I can. The upper, on the human systems, looked at different components of human activities, but the real challenge computationally is how do you couple them? And that coupler in the middle of that slide became quite difficult because with the advent of, let's say, supercomputers, one can make rapid couplers or you could make slow couplers, but the more rapid it became, the more computationally intensive the computer codes had to become. But the challenge right now is how do we couple these human and natural systems on the appropriate time scale so we don't miss information which is critical to how we make these predictions. Let's go to the next slide. And the next slide gets into the real coupling between IAMs, these integrated assessment models, which are on the long time steps and long time scales, with the IAV models on the shorter time steps. And the real challenge is more on the green large box on the left, where we get into the human settlements, human infrastructures, and how one bridges social, behavioral, and economic modeling that's within these components. I would say that's really the frontier, because even as they get into health issues or infrastructure issues, how people respond and different social groups respond really does make a difference in how these model predictions are going to evolve. Let's go to the next slide. And this is a very simplistic slide of what I call generic toolboxes. And this is a very US-centric slide, but I want to say that the Europeans and even the Asian community has very similar types of modeling approaches which are not included here, so this is a US-centric slide. If we look at the activities which DOE, Department of Energy, has been supporting, the GCAM has become, this is the Global Change Applications Model at Pacific Northwest National Lab. This started off as a model with long time steps of order 1 to 5 year time steps going out to a century. And they would combine those with natural system models like the Community Earth System model at NCAR or the new DOE model, which is at the national labs. But the coupling of GCAM with these natural models created a huge challenge because the time steps for each are not compatible. But what one does is define a set of science challenges to at least allow that compatibility, but it really imposes some limitations. And the biggest limitations are how one defines problems so that these time steps and the incompatibility between them becomes allowable. As we move further down, the second row in here is the integrated Earth system model with GCAM. That allowed much more rapid time steps on the order of a month, where we can at least look at some more challenging questions and the compatibility becomes more real. And as we go down even further, we're getting into the space of these impact, adaptation, and vulnerability shock type models, where we're looking at the response of regions to things like hurricanes or other types of disasters. NESAC is a Department of Homeland Security system, which is led by Los Alamos and Sandia National Labs. And I think the real challenge as we go to the next step beyond NESAC is how do we couple these short-term models, which can be down to 100-meter resolution, within these Earth system and climate system models, which are on the order of 10 to 25-kilometer resolution. So there are lots of specific models around which are not included in this slide, many of those focusing on health. And I think the real challenge going into the future is how do we combine health sector or energy sector or other sector models which can be embedded within NESAC or these community Earth system models or GCAM, so that the compatibility of timescales extends down to, let's say, kilometers or even less, and time steps which can be on the order of hours. So I think that's the real challenge computationally. And on the last slide, if you don't mind moving to the last slide now, I'm going to write down a set of what I view to be more significant challenges facing the modeling community, which is appropriate to all of the sectors, especially the health sector. But you can read these bullets, but I'm just going to say that I'm going to look at only a few of them, and that is the damage functions within a lot of these models are defined by thresholds, but they're not compatible across a lot of the model systems. And this needs a hard look at by the funding agencies as well as the performing community, and it applies to the coarser grid impact adaptation, integrated assessment models and the really high resolution vulnerability models, but we need to make these damage functions at least consistent. There are some limitations also in the weather and climate prediction. We fund within Department of Energy a lot of really high resolution simulations involving just the atmospheric component of climate models or the fully integrated systems, but there are some issues which are really badly predicted, such as ice storms and also the details of landfalling hurricanes, and these are the types of issues which can have really severe impacts on infrastructure. Also, the modeling of social and behavioral response, there's been a start to that in a lot of funding agencies, but I think that that is an area that we need a lot of emphasis on how that can be blended in with these natural and human models. And the final one there is complexity and uncertainty management. And the reason I highlight that as the last bullet on the slide is because we've talked a lot about uncertainty quantification within the scientific community. When we started to do that years ago, it was with the intent to attract the decision-making community, but we soon found out that they have their own definitions of uncertainty quantification. And coming up with a compatible approach of what uncertainty means to the decision makers and what it means to the scientists is going to force the two communities to sit down together and decide on what types of definitions and software is going to be required to make these compatible so that the scientific community and the decision-making community can progress together at a much more better pace. Underlying this entire slide is data. We are always fighting the issue that we have an inadequate or insufficient amount of data to really answer questions, and I think that's going to be a real challenge for us also as we move forward into the future. So I think I'll stop there. I've probably used up my time and pass it back to John. So thank you.
Gary, thank you very much. That was a really fabulous opening. I think you've done a great job laying out the universe of models that we're talking about, and these are incredibly thoughtful challenges that I feel like this is a great start for a blueprint for a research and science agenda already. Just as a quick reminder, we have about 240-something participants. We cannot do an open Q&A, but we do have the Q&A function of the WebEx. Please feel free to use it. If we do have time, and Gary, you were extremely timely, I'll take the prerogative of taking one of those questions if we have it. So folks on the webinar, please feel free to use that Q&A function. But we don't have a question, so we're going to move on to our next speaker. And our next speaker is Dr. Judith Matrani-Reiser. She's the Director of the Disaster and Failure Studies Program at the National Institute of Standards and Technology, or NIST. And as I mentioned, one of our co-leaders of this endeavor. At NIST, Judy leads a multidisciplinary staff that does the fact-finding investigations focused on building and infrastructure failures, successful building and infrastructure performance, evacuation and emergency response systems, in disaster recovery and community resilience. And needless to say, with the fall that we've had and record-setting billion-dollar disasters, Dr. Matrani Reiser has been a very, very busy person, as has her staff in the last few months. So very timely to be hearing from you about this. Dr. Matrani Reiser went to NIST after serving 8 years with Johns Hopkins University on their civil engineering faculty. Her research there focused on the seismic safety of healthcare facilities, performance-based design, community resilience, structured tool development for field reconnaissance, informed decision-making for use in emergency management and policy-making, and the interaction of humans with the built environment. Judy earned her bachelor's degree from the University of Florida, her master's from the University of California at Berkeley, and PhD from the California Institute of Technology. So Judy, let me turn it over to you.
Thank you so much, John. It's really a pleasure to be here with all of you today. And Gary, thank you so much for setting the stage in such a beautiful way. I agree with all of your points at the end of your presentation and have lots of exclamation points in my notes, so thank you. So next slide, please. Fantastic. So I'm going to speak to you, note that my background is structural engineering, so I'll be giving a very much engineering-centric discussion, but I'm very open to integrating lots of different disciplines into my work and the work of my groups. So please note that that's how I'll be approaching the problem. So let's start by looking at critical facilities as buildings. So hospitals are designed to withstand larger loads than other types of buildings, such as schools, commercial buildings, and other types. And they have better building performance when faced with hazards. But, next slide, please. Fantastic. The Joplin tornado caused 14 fatalities at St. John's Regional Medical Center. The hospital lost its main and backup power. Operations were done by flashlight by surgeons, remaining patients were evacuated, and subsequent mobile hospital had to be set up. Next slide, please. The power also failed in New York City during Superstorm Sandy, resulting in the evacuation of hundreds of patients. With doctors carrying patients down dark stairwells, as you can see here in the photograph, nurses operating respirators by hand, and a human bucket brigade of National Guard troops hauling fuel to rooftop generators. Next slide, please. More recently, after Hurricane Maria hit Puerto Rico, the only hospital in Vieques, the island off the eastern coast of Puerto Rico, lost its power. Dialysis patients found themselves without treatment for days, and they're still operating out of tents in the parking lot. Next slide, please. So maintaining hospital functions is clearly not just about structural building performance. So how do we also account for what I call human infrastructure, or social and behavioral response, as Gary put it? And how do we account for the performance of lifelines, which exist outside of the physical building, such as water, power, and roads, but are hugely important for the functioning of that building so that we can better manage mass care needs? Next slide, please. So hospitals are quite complex, and they require more than good structural building performance to maintain critical medical and non-medical support services. This is a fault tree that one of my PhD students developed to assess the failure of an individual hospital service. The overall tree structure was informed by Barbish and Koenig's Understanding Surge Capacity, where they correctly state that surge capacity is not simply about beds and ventilators, but instead, next slide please, it's about staff. So this is the leftmost branch of the fault tree. Next slide, please. It's about structure, which is the middle branch of our fault tree. And next slide, please. And it's also about stuff, so comprehensive supplies and equipment, which is the rightmost branch of our fault tree. And that's exactly how we set up the tree structure. Next slide, please. So the fault tree shown is for the failure or loss of function of a single hospital service. While I don't expect you to read all the details of the tree, I know that the print is tiny, I do want to bring your attention to the dependency of the single function requiring staff reporting to work, a safe physical space, as well as functioning utilities, and access to the supplies and equipment required by that specific service area. The trees also account for redundancies in the facility, such as backup power generators, stock supplies, and alternative water sources. And like this tree, we developed many trees to cover more than 20 key services provided by acute care hospitals here in the U.S. Next slide, please. Since 2010, I've been collecting empirical data with my colleague, Dr. Tom Kirsch, who is now the director of the Center for Disaster Medicine and Public Health, and is also here with me today. We have used this data to quantify overall loss of function of hospitals after major disasters as an aggregate of loss from individual service areas. So one very key difference or important contribution that I'd say that Tom and I and a lot of fellow researchers made was developing a structured survey tool that was looking at not just the physical damage of these facilities, but also the reasons for why they were losing functionality, and absolutely capturing when that loss of functionality was dependent on damage, but also capturing when that loss of functionality was dependent on loss of supply chains or loss of human infrastructure or other interruptions. And doing that in a structured and systematic way is really the only way to start building our data so that we can better understand why hospitals perform the way they do after a major event. So going back to the slide, this total loss of function in hospitals is plotted over time, provides a resilience curve for a hospital or any type of facility really. In this plot, the y-axis corresponds to the aggregated functionality of the hospital. So that means total, looking at every one of these individual functions and then adding them. So that at every time step, we're looking at where total functionality is for the hospital, where the number 1 corresponds to fully functional and 0 corresponds to completely non-functional. The x-axis corresponds to time in days. And so we have plotted the data collected in the field, and for the data that you're seeing here is data from New Zealand after we deployed to look at impacts of hospitals after the Christchurch earthquake a couple years back. So it's looking at the data collected in the field in red and the simulated data from the fall trees in the dashed black line. The two curves track each other well over time, except for the discrepancy in functioning immediately after the earthquake. And now this discrepancy is due to heroic human actions that our models just really cannot yet capture. The insert in the blue box is one of the proposed resilience curves proposed by Bruno et al. From Buffalo, showing that Christchurch Hospital's recovery is following their proposed exponential recovery curve. Next slide, please. So our ability to model loss of function explicitly enables us to potentially design hospitals in a very new and novel way. So instead of only focusing on the structural performance dictated by our current building codes, we can use most of the steps that we already take to design buildings and additionally predict damage conditioned on structural and non-structural building performance, repair times conditioned on damage, loss of function, condition on the completion of repairs. Now we're towards the bottom of the circle, and then we're going to wrap back up around. And finally, resilience, condition on the expected hospital functioning over time. And this design process can be iterated as many times as required until resilience goals are met for a single facility. Next slide, please. So another one of my PhD students worked on assessing the impact of structural designs on overall hospital functioning. She worked with colleagues at ERA, which is a structural and architectural engineering firm, to ground her work. And she compared a base isolated design of a hypothetical hospital located in Northern California to a traditional design of the same facility. So again, what you're looking at are resilience curves for this hospital with two different designs. The one on top is a resilience curve for the base isolated model. The y-axis is, again, percent of functioning of the overall facility, and the y-axis is time. And the curve on the bottom is a resilience curve for the traditional design of the same facility, again, where the y-axis is functioning and the x-axis is time. And as you can see, there's a huge difference in hospital services just by making a single very important change in the structural design of the facility. impact of functioning is quite significant. Next slide, please. While the functioning of an individual facility is important, we recognize that health systems in a community are made up of many different types of facilities, not just hospitals, that are supporting the delivery of care. We call this network system of buildings a critical infrastructure-based societal system, or a CIBS. The top layer of the CIBS represents a community function. This could be healthcare, it could be education, it could be governance, it could be sustenance, it could be any major societal dimension for that community. And it depends on lots of interconnected and dependent distributed lifelines that you can see below, as well as policies that dictate the interactions amongst these facilities. A system of systems approach needs to be taken to address the overall functioning of, say, the health system. And this is a very complex problem that we're currently tackling with colleagues from the Johns Hopkins University, George Mason University, the University of Delaware, and the University of Maryland, College Park. Next slide, please. And you can use the systems approach to highlight potential vulnerabilities in a health system. So for example, here's a network structure for the healthcare system in the Canterbury region based on staff sharing agreements, including the facilitation provided by the Canterbury District Health Board, or the CDHB. Now the CDHB serves this need through management of one tertiary hospital, which provides nearly all acute care for the region, 5 specialty hospitals which provide only specific services such as geriatric care, labor and delivery, and elective surgery, and 8 small rural hospitals which provide general medical services to outlying communities. And so what you see here is on the left-hand side is a map of where all of these facilities are, and on the right-hand side you see a graphical representation of how these facilities are networked because they have the overarching branch of the Canterbury District Health Board managing them. Next slide, please. The left diagram shows the same network structure, but now excluding the facilitation provided by the CDHB. The black lines indicate that directed edges exist in both directions, and gray arrows indicate directed edges that exist only in that direction. The right diagram shows the network structure based on staff sharing agreements excluding the facilitation provided by the CDHB, and with the complete loss of 2 facilities, the Christchurch Hospital and the Christchurch Women's Hospital. So the network topology confirms a potential vulnerability, that the loss of the campus that contains both the Christchurch Hospital and the Christchurch Women's Hospital results in a very disconnected graph, effectively creating islands for healthcare delivery. This exercise shows the capability of integrating failure analyses from nodes or facilities with other non-physical networks, such as MOUs, or Memorandums of Understanding. Next slide, please. So I'd like to end my talk today by talking about what still needs to, a lot of work that still remains, but I strongly believe that the future is bright. So I'll go through a couple of these and then highlight some of what Gary said before. So we absolutely need improved models that include interdependent critical lifelines and supply chains. We need models that interface multiple scales, building, institution, and community. And here I'll add Gary's point or strengthen it about integrating models with the capability or compatibility of different time steps. I think that's critical as well. We need models that propagate uncertainty from hazard to healthcare delivery. We need performance metrics that are relevant not just to the entire system, but to specific stakeholders that are managing these institutions. And 100% agreement with Gary, we need more data, so much more data. I want to add that many researchers, including the ones I've already mentioned, current researchers at NIST and our Center of Excellence and many other universities and other agencies are tackling some of these very important modeling problems. But we absolutely need to start integrating a lot of these siloed models. And next slide, please. I really couldn't do any of my work without an excellent staff, and so really all this work is a big thank you to them. And thank you all for listening. I appreciate it.
Great. Judy, thank you very much. That was an excellent presentation. I'm noting some really good questions coming in on the Q&A, but I think what I'm going to do, looking at the questions, is to hold them for now. I think that Some of our subsequent presenters may address some of the questions about, one of them is about how does hospital functionality and loss of function in isolated, non-isolated hospitals relate to casualties. So perhaps that is something that Dr. Hooper will be able to address in some ways in his presentation, and to the extent not, we will come back to these questions at the end. We are saving that time. So, and thank you, Judy. And with that, our next presenter is going to be Dr. Nathaniel Hoopert. Dr. Hoopert is an international, but also an internal medicine physician and a public health researcher in healthcare operations research with a special focus on public health emergencies and response logistics. Since September 2000, he's collaborated with local, state, federal, and international public health officials advancing clinical and health system preparedness for bioterrorism and other public health emergencies. He's led the development of 2 U.S. healthcare planning documents, one the Community Guide for Public Health Preparedness, the other the Guidebook for Hospital Preparedness Exercises. Dr. Hooper was the founding director of the Preparedness Modeling Unit at the U.S. Centers for Disease Control and Prevention between 2008 and 2010. And he served on the Science Advisory Board here at the National Institute of Health's Modeling of Infectious Disease Agent Study, otherwise known as MIDAS, from 2012 to 2014. And Dr. Hooper has been a senior medical advisor to the Biomedical Advanced Research and Development Authority, otherwise known as BARDA, and the National Healthcare Preparedness Program from 2014 to 2016. Most recently, in addition to his academic position at Cornell, he served as a senior advisor for the CDC's Division of Preparedness and Emerging Infections. Dr. Hooper trained at Harvard Medical School, the University of Pittsburgh Medical Center, and the Harvard School of Public Health. So, Dr. Hooper, the floor is yours.
Thanks very much. I just want to check that everyone can hear me.
You sound great.
Okay, great. And I'm going to see if I can control the slides. I appreciate the opportunity to speak with everyone, and I am honored to be among such distinguished speakers. So if you can just confirm that the slide has changed.
In real time. We're very good.
Okay, good. So this is one of 2 quotes that I'm going to use from my senior engineering colleague, Jack Muckstadt, who has taught many generations of supply chain and operations research students up at Cornell. I think we should just keep this in the back of our mind when we talk about models, that the point is not the model. The point is the solution to the problem that we're trying to model. This is material that I'm sure everyone on the call knows, but it is interesting to try to just stack up these mass casualty events or near mass casualty events. The ones that are in the non-italics are natural events, obviously flu, storms, earthquakes, floods, infectious diseases, and then in the italics, things that unfortunately humans do to themselves. These are either intentional or unintentional events caused by human activity. When thinking broadly about modeling for public health emergencies, if you take at least one step back, you realize what a broad set of disciplines and expertises are needed to really do justice to the complexity of what's happening on the ground. This is just a cartoonish way of trying to bring all that together. And as you can see, the range goes from risk sciences and political science all the way over on the other side to ethics and economics. And in the middle there, you see things that have been discussed in the previous 2 presentations. What is the impact? Who may be affected? What are the public health consequences? And what I'm going to stress in talking over the next couple of minutes is what can be done and how perhaps operations research and engineering and logistics can be brought in. And the problem is, of course, that when you think about healthcare, it's easy to miss how complex it is. This is this is real data from the operation of an incredibly simple clinic in New York City. And what we've used is a process modeling program working on very accurate timestamps to paint a picture of how patients flow through this extremely simple clinic. You can see that most go from registration to billing or to a doctor's visit and then to a lab and then to a procedure, and then they leave. The problem is that this is my effort to create a appealing visual when in fact the the actual picture looks much more like this. And when you do the analysis of the patient flow through this, what is probably the simplest outpatient clinic on this hospital campus, it turns out that although 55% of people take 1% of the paths, 40% of the paths are traversed by only one individual. And so you have, we believe we're trying to show this in multiple scales in our research now, you have a preponderance of very unique paths through healthcare. And when it comes to trying to think about how mass casualty events with a surge of patients coming in should be treated or can be treated by a healthcare institution, it is not appropriate to ignore that complexity. So an early version of an attempt to think about mass casualty treatment was, in fact, guilty of that sin of ignoring that complexity. And we did that because we had to make a first pass at this. This was a project that was funded by the Agency for Healthcare Research and Quality and was conducted with Apt Associates up in Boston and Rocco Casagrande and Griffin Scientific, who made the casualty generation component, while we at Weill Cornell made the treatment component. And as you can see, we highly simplified what a hospital looked like. And we calculated, and I'm just giving here an example of the types of calculations of the paths that patients took for influenza. We had a moderate and a severe type of influenza. And you can see these little proportions here, essentially governing the Markov model of state change, of going from the emergency department to the floor, perhaps getting sicker and going to the ICU, perhaps getting less sick and going back to the floor. What this was used for was to generate aggregate healthcare resource use estimates for a variety of scenarios. Again, here, this is just an example of one that was used, the baseline influenza case. And it generated some very pretty pictures of arrival patterns and tried to drill down onto each of those bars with lists like this. And this is an attempt to estimate the daily resource requirements for, as was mentioned in the last talk, staff, stuff, and other types of ancillary required materials in the settings where patient care was taking place. And you can see that this includes in the green, beds, in the pink, people, in the yellow, a set of resources specifically for mechanical ventilation of patients, et cetera. The list for this model exceeded 150 items. And unfortunately, the surge model had some limitations. It did not distinguish time frames or locations of events. It did not include the impact of actual resource availability on clinical outcomes. So, for example, as I'm sure most people on the call know, we're currently experiencing a severe shortage of IV saline bags due to decreased production in Puerto Rico due to Hurricane Maria. In fact, it also did not cover what we now, in the subsequent decade, know are the most common of these mass casualty events, at least from a terrorist perspective, bombings and motor vehicle accidents. And furthermore, it did not reflect the capabilities of supply chain sustainability in the event of a long-term event. So where does this bring us? I should also mention that the surge model had to be turned off in 2009 because of a lack of funding. So it was useful for several years, and it really hasn't come back on the scene in its original or augmented form. Where does this leave us? This leaves us with a couple of caveats about attempting to model mass care. One is that healthcare is, of course, complicated. It has many moving parts, but it's also quite complex, and perhaps we saw a little bit of that in the way that the recovery from severe impacting events was faster than predicted by simplistic models like exponential curves. However, even though complex systems are difficult to control, even a little bit of control may lead to much better outcomes. And to gain that control, and this is really, again, ideas coming out of the world of supply chain management, you need at least these 5 things. You have to know your user requirements, the patient's requirements, and hospital's functioning requirements. You have to construct organizations with low variability in the way that they conduct their operations. And perhaps this is where HPP's healthcare coalitions really come in. And in addition, you need these 3 additional pieces. One is an information infrastructure that works in the disaster. And second and third, business and decision processes that work during these disasters. And the next slide has a picture that comes from one of my colleague Jack Muckstadt's papers earlier in the last decade that tries to give a sense of how we go from where we are now, which is mostly in the yellow and the blue, which is that we have relatively static information systems, perhaps that are updated, for example, bed counts. We have some anticipated events, but we don't really have a playbook the way perhaps some other countries, such as the UK, have, where you can reach into a drawer and say, we've already run this pandemic flu model. Let's see how we did when we simulated it. And then on the vertical axis, collaborative decision support is actually something that can be exercised and is something that I think is rarely truly achieved in the kind of structured exercises that are done, at least ones that I've participated in, but it is the goal. Let me just finish up with a couple of pieces of information. One is a study that I participated in that's just been published in the last couple of months, looking at the impact of coastal storms on patient flow. And what you can see in the black here is that in New Jersey, in the most severely impacted counties, the data suggests that there was about a 21% increase in Medicare admissions. And that number was remarkable mostly because in the prior years, ASPR and the HPP Office of the Department of Health and Human Services had been recommending that hospitals prepare about 20% of their beds for additional surge capacity during such things. So when we start looking into the data that's available, but which is expensive and difficult to get, I'll acknowledge, it turns out that we can actually start to judge whether some of the policies that we've engaged in are actually on the mark or not. And the next slide is just a snippet of the work that we've been doing with the Fire Department of New York that shows complex changes in EMS activity in the aftermath of the knockout of the hospitals that were mentioned in the last talk, which, if you can read the slide, would have sat between the Beth Israel Hospital and Cornell Hospital, right in the middle of those red increased activity marks. What's interesting about this slide to us is that it not only shows increased activity in the surrounding hospitals around the areas that were most impacted, but decreased activities in other parts of the borough of Manhattan, indicating that you can't simply make simple assumptions about how health systems are going to respond to these devastating events. So finally, last slide, I just want to mention a couple of things, and this is largely influenced by my discussions not only with Professor Muckstadt, but also with Robert Gougelet, who's a very experienced emergency responder and has been working in especially the New England area in the United States for many decades. The first is modelers should be very careful about their choice of scenarios, and they should be sensitive to the fact that choices for national or regional levels may not be appropriate for local activity. The second is that the type of model needs to be appropriate for its intended audience or its intended audiences. We can have strategic models looking out years, as noted in the first and second talks, all the way down to operational models, which are supposed to be used in real time. And I would add that, given my experience so far, I think it's unlikely that we'll really have a wide variety of these operational models. There are some, like plume models, that fit the data and the needs very nicely, but others that probably will not stand the test of time in the field. Furthermore, these models need to be addressed to everyone from senior policymakers down to field teams. Some can do all of those, but most will do one sector or another. Model parameterization, as we discovered, making that very long list of resources for the SURGE model back in 2006 through 2009, is extremely difficult. Most people don't capture this data. New electronic medical records may make this easier, but it's still a huge challenge to gather dynamic casualty numbers and types and severities in their locations, as well as dynamic resource requirements. And what I would end with is that all modeling needs to aim for tighter integration with patient management. And there are things that are going to be introduced, for example, call center-based triage, that will radically alter how patient flow will evolve over the course of events. And modelers need to know these things, and they have to work basically side by side with responders. And one of my other advisors and colleagues, Martin Meltzer at CDC, has been quoted as saying, if you're not elbow to elbow, you will not have an impact, and I firmly believe that. So I'll leave with a quote from Jack: the way that you are going to design your system is a reflection of how much you think you are going to know about the system. And what he means is know about the system while the system is supposed to be responding to your disaster. Thank you.
Great, Nathaniel. Thank you very much. That was an excellent talk. And again, I think it really blends well with the first two talks, is giving us a fuller and fuller picture. Everybody has a lot of questions. We've got good questions coming in. I'm just going to move on to our final talk. And then thank you to those posting the questions on the Q&A. We will get as many of them in, and they're such good questions, I am going to make a commitment that we will find a way to post a Q&A from this webinar when we post the recording of this as well. So with that, let me introduce our final speaker, Dr. Ian Krasounis of the Pacific Northwest National Labs. Ian's the Director of the Atmospheric Sciences and Global Change Division there. He serves also as Principal Investigator for the Integrated Multi-Sector Multi-Scale Modeling, or IM3, scientific focus area, so quite relevant to our topic today. Prior to joining the PNNL, Dr. Krasounis was a Senior Program Officer with the Board on Atmospheric Sciences and Climate at the National Research Council of the National Academy of Sciences. There he led a number of projects and reports related to climate and global change. He received his PhD from the University of Washington, where his graduate research focused on using numerical models to study the large-scale tropical circulation. His undergraduate degree from the University of Virginia. And Dr. Krasounis will talk to us about the development of integrated impact assessment modeling platforms. Ian, over to you.
Thank you, John. Can everybody hear me okay?
Yep, you sound good.
Yep.
All right, great, thanks. And thanks for the invitation to join. I really enjoyed the previous speakers' presentations, and I'm going to present something that's a little different and going back to some of the ideas that Gary introduced in his slides on the sort of need for integrated analysis of multi-sector interactions, and stepping back and taking a bit broader view of that from not just the perspective of the health sector, but other sectors that in some ways have some unique features, but in many ways I think have a lot of similar features to the kinds of problems and the techniques and tools used to address them that were presented in the previous two talks. So I think there's a lot of synergies here we could build on and learn from each other. So I'm going to start with an overview of this project that I lead, the Integrated Multi-Sector Multi-Scale Modeling effort that's funded by the Department of Energy. And at the end of the talk, I'm also going to share a couple of slides on related projects being led by some of my colleagues here at PNNL, and finish up, like a couple of the previous speakers did, with some lessons learned, some of which are going to be highly synergistic with some of the ideas that they presented. So Here's the second slide, just to give a little bit of context and background for this flavor of work, building on what Gary introduced. There's been a number of studies in the sort of climate and global change impact literature that have pointed to a need to better understand the complex interactions amongst different human and natural systems and how those propagate through when you're trying to understand the impacts of either an individual extreme weather event on infrastructure systems or things like that, or more generally trying to understand some of the potential implications of long-term climate change, and particularly when those things are layered on top of some of the extreme events and how those might be changing. So just to give a couple of examples, the study on the top left came out in Nature Climate Change a couple of years ago, and it looked at what happens when you couple an integrated assessment model that sort of represents all sectors or many sectors at a fairly coarse degree of resolution, both in terms of process resolution as well as spatial and temporal resolution, and you couple that with more highly resolved versions of some of those individual sectors. So do the impacts go up or down if you start resolving things in greater detail? And what they found was it's all over the map. It really depends on what sectors you're coupling, what way you're coupling, what problems you're studying, and it really is important to gain a comprehensive overview of how these systems interact with each other. The middle graphic here shows a workshop that was led by Gary and Bob Valerio, one of the program managers in Gary's division at DOE, and other colleagues from the U.S. Global Change Research Program. And John, I believe you were there as well, looking at the sort of complex interactions amongst these kinds of systems and what sort of frameworks are needed to represent those systems, both from a technical perspective as well as communities of practice where we can learn from each other in these different sectors in how to best bring together models, particularly ones that are coming from very different modeling backgrounds and traditions and formats, et cetera. Finally, in terms of the sort of impact and need for this style of work, more on sort of the climate and weather impact side, there's been a number of, there's been a lot of attention lately, particularly in sort of the climate, reinsurance industry and things like that, that point to the need to better understand how big these changes might be and how they might impact various institutions and parts of the economy. So that's what the third graphic there indicates. So I'm going to start, or I'm going to next move on to a high-level overview of what do we mean, since this is a little bit of a different topic, what kinds of things do we need to think about when we're modeling the impact on the energy system of a particular weather or climate event, either in the short term or the long term. So if we're thinking about the impact of weather on the electricity system, we actually need to think about its impact on various subcomponents of that system. So thinking specifically about a heat wave, which you probably know is one of the things that stresses the electricity system the most. They actually have multiple impacts on the system. For example, it reduces the efficiency that power plants operate at. It reduces the efficiency of the transmission system where energy is transmitted. And it also increases the demand for space cooling in both commercial and residential buildings. And all these things sort of happen at once, and you need to resolve them at the same time to really understand the true impact of the heat wave on the system. We at PNNL, as well as others, have developed modeling tools that are designed to look at the interactions of these systems. And many of those tools are borrowed from sort of things that were developed in the industry or for other purposes. For example, our model of building energy demand is based on a model that was developed to look at the impacts of different building codes and standards and how those influence energy efficiency of particular structures. And we've taken that and aggregated it and put it into a context where we can understand and model what is the impact of a heat wave on the demand for electricity in a particular sector, assuming a certain sort of distribution of population of buildings in that location. So it's not, I should also add that when you think about the impact of a heat wave, that may not be occurring in isolation. The electricity supply system in particular is very strongly dependent on the availability of water, both out here in the West for hydropower production, as well as cooling power plants. And that includes both having enough water as well as having water at a cool enough temperature to be efficient at cooling power plants. So when you so just modeling the effects of a heat wave is not enough. You also have to understand how the weather and climate system is influencing regional hydrology, other water demands for agriculture, et cetera, and how that affects the availability of cooling water and hydropower for the electricity production system. But it doesn't end there. You also want to not just look at a particular weather or climate event, but you want to look at multiple scenarios of different weather events or extreme events that could occur in combination or in isolation over a longer time period. And you want to do that not just looking at the current infrastructure, but various incarnations of the future infrastructure that might arise due to various energy policy choices, due to different sort of regulations, as well as due to the, choices that different investors and different parts of the electricity community make with regards to how they build out the grid, how different power plants and energy sources are developed, and how buildings sort of evolve over time. So you want to understand multiple scenarios across this entire framework, and then understand how those things then feed back to other parts of the system. And this is where it can get very tricky, because you need to understand, for example, how changes in the electricity supply system at the regional, national, and global scale might feed back in terms of global greenhouse gas emissions, as well as on things like stream temperature, where the electricity supply system could actually be very constrained by the availability of cooling water. And we can do this in an integrated modeling framework, but it's very helpful to have a sort of tool that can shape this and provide consistent scenarios for all of these different sectors. We use some of the integrated modeling tools that Gary introduced, these integrated assessment models, or IAMs, to generate a consistent set of scenarios so that you're building out a future incarnation of the energy system that is consistent with a particular sort of Earth system climate scenario. So we can use these tools to address a number of different questions, and you'll see that these are different but also very similar to the kinds of questions that the previous speakers were discussing in the healthcare sector. So looking at trade-offs between emissions reductions and resilience enhancement. So in the healthcare system, this might translate into sort of capacity versus resilience in terms of responding to a particular disaster. We need to understand, when we're passing information across these different parts of the framework, what are the various temporal scales of these models, what degree of model coupling is needed, what are the data needs to calibrate and validate these models, and how accurate are these simulations, getting a handle on the uncertainty that's inherent in them. And this is just a sort of a snapshot that picks out a particular set of systems here. There are, of course, a whole host of other factors that one needs to consider that I'm ignoring here for the sake of simplicity, and you have to do a sort of a first cut analysis just to understand whether you need to account for things like urbanization, restrictions on power plant siting associated with air quality, feedbacks that might be associated with water used for other purposes. The natural gas system is very important to understand, because that is increasingly a source of fuel for the electricity supply sector, and if the natural gas system is impacted, that has cascading impacts on the electric grid. So there's a host of other tools that are needed to be sort of included to fully understand these impacts. So I'm just trying to give you a flavor for the kind of complexity of just one piece of this system, and hopefully you'll see some analogs here for the healthcare sector in general. So here's an overview of this IM3 Scientific Focus Area project that I lead. This is funded by the Integrated Assessment Research Program in DOE's Office of Science, where Gary works. And there are basically three goals of this project. One is we are trying to develop this framework that captures not just the interactions I just highlighted, but also captures things like land use and land cover change, socioeconomics, critical infrastructure, and other sectors. We want to use this sort of dynamic framework to study vulnerability and resilience of these coupled human and natural systems to both short-term events as well as long-term changes of various sorts, and really look at in detail in how different levels of complexity, spatial and temporal resolution, how the models are coupled together, how that influences the fidelity of the simulation, as well as uncertainties and how those propagate across the modeling framework. And I should add that this project is led out of PNNL, but it involves 3 other national laboratories as well as a host of university partners, and it really is intended to be sort of a long-term home for this type of research branching out over time into other sectors. Just to give one snapshot, this is a specific incarnation of that sort of energy and water system high-level overview chart that I showed. A lot of my presentations, by the way, tend to show a whole bunch of boxes and arrows. You know you're talking about a multi-modeling framework when you got a lot of boxes and arrows. And these are sort of the names of the specific models that are included at a watershed scale simulation within our framework, as well as at a regional scale. We try to force these with different scenarios of not just climate, but also socioeconomics, energy system developments, et cetera. And for any individual sort of experiment that we run or question we're trying to answer, we don't use all of these tools necessarily all at once. We may use a subset that's needed to address the specific question that we're asking here. And there's a web link here and also included on my final slide if you want more information either about this part of the framework or more generally about the project. Moving on to just one other area that is perhaps a little more relevant in the health sector or has more immediate interactions with the health sector, we're also doing some work in population dynamics modeling. This is led by Brian O'Neill, currently at NCAR, although moving to another institution very shortly, and some of his colleagues. And really this is designed to look at demographic dynamics. And of course, this is important because it's the ultimate driver for energy use, water demand, et cetera. And we also are interested in providing scenarios for U.S. population that it can account for things like internal migration within the U.S., which is something that's been challenging to resolve in population models, previous population models, and also looking at a host of different future scenarios of how population might evolve. And to do this, you need to look at, let's say, at an individual state level, which is where most of this data is collected. You need to understand not just sort of the pattern of migration and how that might be influenced by climate, but you need to have data, both current rates as well as projections of future fertility and mortality rates. And obviously, that's something that could be provided with additional information from the health sector. So that's something we're looking to build out in the future. So I'm going to move on now to sort of our longer-term plans for the IM3 project. And so this chart shows different sectors and the components within those sectors that we ultimately would love to include in the framework. So the ones that are sort of bright-colored with solid lines around them are the components that currently exist and that we currently have integrated in some fashion into the framework. And the darker dotted line ones, boxes, are the sort of our dream of things that we'd like to include in the future. And so if you look at this, you'll see that we are including a number of different current sectors, but there's another additional sectors like the healthcare sector, like the transportation sector, where we know there are tools out there. In some cases, we're quite familiar with some of those tools look like, and we're looking to build those in and build on some of the progress in those individual communities, but look to bring a sort of multi-model, multi-scale perspective to those simulations to add to the types of questions that they can ultimately answer. And we're looking to do this not just in our project, so we would love to include some of these additional sectors explicitly within our project framework, but we're looking to build tools and partnerships such that we can advance some of these capabilities through collaboration. So if you are interested, we'd love to hear from you, understand what kind of tools that you are currently working with or are looking to develop, and how we can potentially build and help one another in doing so. So that was my overview of the IM3 project. That's one specific example of the sort of integrated analytic framework for impact analysis that we've been developing. Some of my colleagues are working on other types of problems, so I'm going to move on here to some work that my colleague Manish Srivastava has led here at PNNL. And this is looking at a very different type of integrated modeling. So this is integrated modeling of atmospheric transport of pollutants and their health impacts. And specifically here looking at polycyclic aromatic hydrocarbons, or PAHs, and these compounds have some climatic relevance in terms of sort of atmospheric energy balance, but they also are known carcinogens. They have effects on ecosystems, so it's really important to understand their abundance in the environment as well as how they're transported after they're released through various processes. And there's been a known gap here in that when we go out and measure these compounds in the environment, the concentrations are much higher than what we were getting out of our models of these compounds and their propagation. So based on some laboratory work by Manish and his colleague Alice Zelenyak, they determined that there is actually a process going on with these compounds that affects these compounds and their ability to survive in the atmosphere. Namely that previously they were modeled as being sort of free or unbound particles in the atmosphere or things that could be exposed to oxidation processes during their transport. But their laboratory experiments showed that in fact there was sort of a viscous coating that forms in the atmosphere around these small little particles in the atmosphere, and that can effectively trap them and make it hard for them to oxidize or sort of be exposed to the environment. And this essentially protects them and allows them to be transported over much, much longer distances, as well as increasing their atmospheric abundance over time based on or compared to the previous models. So Manish's
I'm sorry to interrupt, but I just need to give you a time check. We need to have you wrap up.
Okay, I'll finish up in 1 minute. So Manish and his team looked at this and found that there was a significant increase in the concentrations, and coupling this to a risk model showed that the global lung cancer risk increased by up to a factor of 4. So I'd encourage you to check out his work if you're interested. My final slide, I will just breeze through very quickly. This is work supported by the Department of Homeland Security's National Infrastructure Simulation and Analysis Center. Here at PNL, point of contact is Tim McPherson. I can provide his information to anybody who's interested, and they look at various infrastructure tools and how to link them together, and specifically focusing on the health sector. They developed a tool that was able to look at the spread of contagious disease, answering questions like how do these diseases, either natural or human-induced, propagate across the population? What are the effect of various measures that can be taken to mitigate them? Like the system I was describing, it really is a multi-sector modeling tool that can allow the team to look at various components of how things propagate across the community. I'd love to put Tim and his partner, Brent Daniels, in touch with anybody who's interested in kind of comparing notes on these sorts of processes and procedures. So wrapping up with just a couple lessons learned. First, I'd like to agree with all the comments of the previous speakers in terms of the lessons learned that they shared, particularly with regards to the need for data and careful attention to scenarios. We definitely have found that you really have to pay a lot of attention to the assumptions you're making, the computational requirements, and what information you're passing between models. And this gets especially difficult when you're implementing feedbacks across different sectors and coupling between models. So you really have to start small and build these frameworks over time. Also, you have to be careful that you don't over-engineer things. You're not trying to build this incredible thing that can simulate the entire universe. Just use the components and the feedbacks and the models that you need the question that you're trying to answer, with appropriate attention to modularity, repeatability, flexibility, utility, and best practices in software engineering. Thank you.
Wonderful, Ian. Thank you very much. And a huge thanks to all of our speakers for really informative and really spot-on presentations. We are going to now do some Q&A. We've gotten wonderful questions in. I'm going to say a couple things about this. The first is that some of the questions are pointing to some of the operational side or implementation or the interactions with emergency response. And I just want to remind folks that we are going to have a webinar 1 week from today with that community. And what I'm going to do with some of those questions is to provide them, sorry, we've got some background noise, okay. I'm going to provide them to our speakers in the next webinar and hope that we'll be able to address and inform their presentations next week and get them in that way. I'm going to try, and at some risk, I'm going to try to integrate some of the questions that have come in and group them. And again, I'm going to ask our presenters, I may direct them to some of our presenters and ask them to be extremely succinct and as quick as possible in their answers so that we can try to get to these questions. So the first thing I'm going to group is we had a question. Gary, in his very first talk, made the point that across the different sectors and the different kinds of models, there is inconsistency and sometimes incompatibility in the damage functions. And he didn't define damage functions. We didn't talk about damage functions. We had a question about what a damage function is. So I may ask Ian and maybe Judy, and actually, I don't want to spend a lot of time on that, but I think that damage function is one of those terms that means different things to different sectors and disciplines. And what I'd like to do is to incorporate that with a consideration of another question which came in. So we have the damage function. We also have vulnerability functions when we do this kind of modeling. We have something called social vulnerability indices. There are several of these, and a good question came in about can the estimation of social vulnerability indices and that vulnerability function, if you will, be incorporated into these dynamic models. And then the last question, which I think is more for Nathaniel perhaps, well, I'm just going to point this to Nathaniel and Ian only for now, just to keep it succinct, is what is our state of the science in terms of being able to estimate the economic impacts on healthcare facilities to take this kind of what Judy termed resilience or this functionality of a healthcare system and translate that into dollars and cents so that can inform the decision making. So Gary, if you're still on, maybe I'll offer it to you because you use the term damage function. Could you just give a very, very short definition of it and maybe a quick elaboration on why you say they're inconsistent?
Okay, let me just start. I mean, there are damage functions all across these models. I'm going to give just an example. One of the functions, one of these damage functions involves falling trees. So one has to at least understand the relationship between soil moisture, tree stability, and what kind of trees they are. Because when a tree falls, it takes down power lines. It takes down houses. I mean, this is one of the examples where some of the models apply damage functions. They might be generic to some regions, and other ones might be more specific to the ecology of a certain region. So that's one example. Another example of the Department of Homeland Security worried about in their NESAC models was when an oncoming hurricane reaches a coastline. A lot of the damages are not just caused by wind damage on the structure itself, but it's things like flying boats. It's trees that are flying. These are some of the more serious damages which are bring down infrastructures. Some models treat those, some of the models ignore them, but these are damage functions which are quite severe, which are difficult to parameterize, but one has to at least incorporate them somehow. And these are just a couple of examples.
Great, and I think that points to the complexity of integrating all of these cascading and compounding impacts on the infrastructure and other things which healthcare facilities are dependent on. Anybody want to talk more on the health side about damage functions very quickly?
So I'll add to Gary's definitions of damage functions. So on the structural engineering side, we too use damage functions, and so we build mathematical models that represent and characterize the structural response of buildings to natural hazards such as a seismic event or wind event. And in these models, we predict damage to very specific components, and these could be, a joint in a building, or it could be an entire floor of a structure. So the resolution, let's say, of these models can vary quite a bit. So I agree with Gary that being very explicit about what's being considered in these damage functions, because there's so many different types out there. We use something called fragility functions. It's pretty widespread now in most of the structural engineering community. It's really critical just to be very explicit, so at least you know what you're getting as input.
Thank you. Nathaniel, can I turn to you and just, so we mentioned that the damage function is intimately linked to the vulnerability in a very explicit geospatial and temporal way. Do you want to say something about the issue of even the static versus dynamic nature of vulnerability and the social vulnerability indices, and what is the state of the art in incorporating those considerations now?
Sure. Actually, I was, while others were talking, I was thinking about the economic component of this. So I'll just mention one thing about that, which is that obviously a lot of the economics of healthcare operations depend on the environment in which you're practicing, the U.S. versus, for example, countries that have a single payer. In this country, in the United States, obviously a decrease in the bread and butter, like the elective surgeries due to dislocation or disruption of services, can have a major economic impact. But it's incredibly tricky to think about a bottom line because of the ways in which emergency healthcare activities are recompensed by either local or federal or state government. So I just, I think that time is certainly overdue for a review of things like this, and if there does exist a review like that out there, I'd be very happy for someone to point me to it. The bigger question about static or dynamic, I mean, obviously everyone saw those illustrations of how quickly hospitals can get back on their feet, and certainly in the absence of, say, hundreds of thousands of oil-tinged water in the basement of a hospital, as happened at Bellevue and NYU, you know, the hospitals do have the ability to typically recover, at least in some sense, in a tent or at a different facility. I think that what we tried to do with the Medicare data in New Jersey was to really try to track the patients. And I would, just as a brief response, I would say that is, from my perspective, probably the most promising approach to understanding in a dynamic manner how patient care and patient reimbursement or payment can be mapped onto these different types of events. I think it would be, now that we have systems, electronic process modeling software, for example, combined with electronic medical records, I think that we are approaching the moment when we can do very large-scale mapping of patient flow during these disasters, which I think is a base-level project for making these things more realistic.
Thank you, Nathaniel. And looks like that's a good area for future work, and also pointing to existing capabilities that we have now because of technological advances that we didn't have before. I'm going to try to squeeze in one more complex question, and I'm going to ask people to answer this in 30 seconds or less, just a very quick response, and it has to do with several questions about what is our state of the science, what is our state of modeling for different kinds of issues. The first one is, and this has been alluded to already by Gary, who said we don't do this, but just if Judy or Ian or Nathaniel want to comment on our ability to model sequential events that are unrelated, like a bioterrorism attack, following a huge storm surge and hurricane. So either sequential unrelated events or really good cascading failures in a causal chain that are kind of bigger than might be anticipated. The second question was, in terms of agent-based modeling, are we doing any agent-based modeling of the hospital staff, as Judy was talking about the importance of the human system within the healthcare system? And then the last is, where are we in terms of incorporating the smaller facilities within a health system, the nursing homes, the ambulatory care centers, the mobile care more frequently becoming important. So we only have like 2 minutes to cover all this. So who wants to say something about the cascading and sequential events?
Okay, this is Gary. I'll start on that one. I think a lot of these sector-specific models work pretty well. Where I start to worry about their capabilities is when you get cascading failure, especially if the region which is being exposed to an extreme event was recently exposed to an extreme event, let's say some months before. In other words, the region had not evolved to some stable state before it was hit again. And in that case, these models really don't do well. I'll just leave it at that.
Great, thanks. That's all the time we have for that one. How about the agent-based modeling of the decisions made by hospital staff?
I'll take a stab at that. A recently published paper by Syed Mogandas and his team in Canada looked at 68 individuals in a nursing home looking at flu. To model those 68 individuals took 73,000 hours for their agent-based model to produce the appropriate sensitivity analyses. At this point, I think that agent-based modeling is too black boxy and too computationally intensive, and there are very viable alternatives such as network modeling and good old-fashioned discrete event simulation modeling.
Thanks. Judy, do you want to say anything to that?
So we've also been using the discrete event simulation modeling, and I support that. We've done some work with agent-based modeling, but mostly focus on evacuation through damaged areas.
Gotcha. Okay, thank you.
I'm going to take the smaller facilities one.
Okay, good.
If you don't mind. So I think this is something that Tom and I have been talking about for a long time, is that, we've been focusing on these acute care facilities and their functionality, especially when you need them in a disaster. But the truth is that some of these smaller facilities that are considered risk category 3 structures, they're not designed the same as acute care facilities. And so when they fail, and they often fail, they surge those other facilities. And so this is something that we need to look at more carefully and integrate the modeling. And so when you're looking at like that SIDS and all that, network of buildings, these are the kinds of things that'd be really nice to take a look at.
Great. Thank you very much. Wonderful answers, very nice and succinct. Wonderful questions from the participants. And again, just because we can't answer them all live now does not mean we will not have this team respond to them, and we will get them up on the website. So with that, we're going to wrap up. I'm going to turn this back over to Tricia, who can give us a reminder of the next event. We've been getting questions about that already from the participants in this event. And again, huge thanks to our speakers who did a really fabulous job. Let's have a resounding applause virtually for them, and Tricia will hand over to you.
Thanks, John. We'd love for everyone to join us on the next in this series of webinars about disaster risk reduction for health systems. We will be talking about engaging stakeholders. Our speakers are Michael Sharon of FEMA, Rick Smith, also the National Weather Service, Melissa Harvey of Health and Human Services, Kimberly Scho from the University of Utah, and Catherine Kennan from Partners Healthcare. You can see the flyer on the slide currently. The link is hard to read on that page, but we do have the link in the Q&A box. If you can't see that, please feel free to email me at tricia.castranio@nih.gov. Thank you, everyone, for participating.
With that, we'll adjourn and look forward to seeing you and colleagues next week.